Hello, everyone. Thanks for joining us today. I'm Jonna, and I'm going to be the moderator for today's webinar. We want to thank you for being patient as we were getting things set up today. We had a little technical difficulty, so thank you very much. I wanted to point out a quick feature of the webinar. There is a questions or a chat panel. If you have questions throughout the webinar, feel free to ask the question, and I will read those to Dr. Smith at the end. We're saving about 5 minutes at the end to go through questions. So without further ado, I introduce Dr. Ryan Smith.
Hi, everyone. Thanks for joining today. Appreciate all of your patience. Our Wi-Fi password's changed here, so I had to get logged in unbeknownst to me. But excited to talk to you all about cataract surgery and some exciting new technologies we have here. So let's dive right in. So what are cataracts, first and foremost? So it's a natural aging process of the lens. You get a clouding of the natural lens due to buildup of protein clumps. So the eye has a lens in it. It's continually putting down new layers. It gets thicker. That changes your prescription as you age. And then as these protein clumps form, they block light from reaching the retina. There's all different forms of cataracts. You can see here this yellow lens here can do it, but also you can get ones that cause glare and halos at night and all sorts of different symptoms. So we're going to go through that. Clouded or blurry vision, right? So this is a really good example. I often tell patients it's like a sunglass inside your eye, but it happens so slowly, you don't even know it's there many times. And so then when we take the cataracts out, patients are like, whoa, blues are blue again, and you have no idea. And they say, oh, but this other eye still has this yellow tint to it, and that's your cataract. Again, you can get glare and halos around night, around lights at night, depending on the type of cataracts that you have. Colors can fade if they're not yellowing. Double vision. Now, if it's double vision with both eyes open, that goes away when you close one eye. That could be something more related to your brain, and we want to get that checked out. But cataracts can cause double vision. So if you have double vision, you close one eye, you still have double vision. It's likely coming from inside your eye, and it might be cataracts. And then lastly, like I said earlier, as your cataract progresses, it can change your eyeglass prescription. You might not have needed new glasses for 5-10 years, and then all of a sudden every 2 years, and then every year, and then every 6 months, you feel like you're updating your glasses. That can be a changing cataract. And most people get cataracts, so it's okay. It's a natural sign of aging. We think it has to do as well with UV exposure over our lifetimes. By age 80, more than half of all Americans will have cataracts. It's very normal. It's the leading cause of vision loss in adults over age 55. And you can have them and not even know it. So, and that's okay. You know, I will always tell my patients whether or not they have a cataract. But some doctors decide that you don't, you know, if it's not that affecting your vision, they might not put it on your note. But just because you see cataract there, you don't have to be concerned. You might still be decades away from needing surgery. And to that point, right, cataracts don't constitute a medical emergency. So you can live with them as long as they aren't affecting your life. If you can't pass, I tell my patients, you know, cataract surgery is only mandatory if you can't pass a driver's test with a new pair of glasses. Then, you know, you can either stop driving if your rest of your life isn't affected, or it's time to do your surgery. But this is where it's more nuanced. If you have stopped driving at night because of glare and halos and just discomfort with your vision at night, or you know, you don't go out when it's really sunny because it's giving you glare, or you've stopped doing activities because you can't see as well. You know, if your quality of life is suffering, there are safe and effective treatments that we can use to give you that vision back, and that's what's so exciting about cataract surgery. It is one of the most commonly, if not the most commonly performed surgery in the United States. There's over 3 million cataract surgeries performed annually, and the success rate is exceptional. There's less than a 1% chance, and less even than that, of any negative outcomes or side effects associated with cataract surgery. It's extremely successful. Patients are very happy. And there's lots of different options for patients, and we're going to go through those. You know, our team here at Pacific Eye has performed thousands of procedures. I myself have performed thousands of these. And it's just a true joy to help restore my patient's vision when you need cataract surgery. So how do we do it? So a small incision is made on your cornea. Your cloudy lens is then broken into little pieces and removed from your eye using ultrasonic energy. And a crystal clear artificial lens is then implanted into your eye. Classically, only one eye is treated at a time, and I prefer this approach. You know, if you go to Kaiser, you might see they do both eyes on the same day, but we learned so much about your outcome from your first eye to help plan and fine tune the second eye. Refractive cataract surgery, where we're really going for optimal visual outcomes, it's best to do one eye at a time so we can get all of the data, use your eye as one of those data points, and get you that best outcome with both eyes working together. You might have heard about laser cataract surgery. That's out there. It only does this first part, okay? It does not perform your whole surgery with a laser. You're still using ultrasonic energy to break apart and remove the lens. And, you know, we manually put a new lens in the eye. So it's out there. There's been no data to show it's better than traditional cataract surgery. There's been no data to show it's worse. So, you know, some doctors choose to use it. I've been in practices that have used it. I'm experienced with it. Personally, I don't think it adds anything other than cost to the surgery to you as the patient, and there are better technologies that we've chosen to implement, and we'll go through those. So when we do cataract surgery, there's different lenses that we can choose, and we're going to toggle between this slide and a vision simulator so I can go into more detail with you about this. The standard lens that's covered by insurance is called a monofocal IOL. So that means it gives you clear vision at one focal point, either distance or up close, right? So, you know, before surgery, over here, let me get my highlighter on, you know, over here we're talking everything is blurry. After surgery, this patient here has had a distance monofocal lens. So clear vision of the child, but the phone is blurry. And then there's these lifestyle options we'll talk about that can really reduce your need for glasses after surgery. So I'm going to run through the types of lenses that we can put in, and then we're going to go over to the simulator here. There's two main ones, or three really main ones that you'll hear, and then one older one that some people still use. So the extended range of vision or extended depth of focus are two terms for this lens, also abbreviated EDOF. It creates an elongated field of vision. So these lenses will give you distance vision and intermediate vision. Think of distance vision as anything beyond an arm's length. Intermediate vision is anything, you know, kind of like your elbows partially bent, and then close vision is your reading vision where you're holding something up close. So these can give you distance and intermediate. So dashboard, computer, cell phone, and then your distance vision, but you're wearing reading glasses. There are trifocal lenses out there, like the Panoptics, or my favorite is the Synergy lens. They have an exceptional combination of near, intermediate, and distance vision. So it significantly reduces the need for glasses. They do use some rings to split the light, so you might have some glare and halos at night, which we'll go through the simulator. And then there's toric lenses, which come in monofocal and multifocal and trifocal and everything variations. These correct astigmatism. So when your cornea, the outside layer of your eye, is shaped more like football or kind of like a lemon instead of an orange or a basketball, that changes how you see the world. And you might have had astigmatism your whole life, or you might be told that you needed or are a candidate for an astigmatism correcting lens, but have never had astigmatism. Well, we have corneal and we have lenticular astigmatism. So our lens has astigmatism in it, and oftentimes our bodies are smart, right? Evolution is smart. Our lens will develop to cancel out astigmatism from your cornea. But when we take out your cataract, we've now taken out that lenticular astigmatism, and we reveal your corneal astigmatism. So that's why sometimes you might benefit from an astigmatism correcting lens, even though you've never had astigmatism. And then multifocal IOLs, these also have rings. This is an older technology. It'll give you two focal points, but it could be near and far, and then you don't have computer vision. These can be useful for some patients, but they're kind of going out of favor. Give me a second here. Let me toggle over my annotations, and we can go through the simulator before we jump into these exciting technologies that we have. So hopefully you all find this helpful. This on the left here is your condition. On the right is going to be the treatment, okay? So let's say got a pretty significant cataract. So the world is pretty yellow and cloudy, right? And that cataract's made you nearsighted. So it's just all really blurry. Well, so standard cataract surgery with a monofocal lens will clear up that cloudiness and look at the clock on the wall. So the clock on the wall over here, right? Nice and clear. The computer in the distance is clear. Your window outside is clear. So think about how this affects your driving vision, right? Here's another, I like the book example too, your cataract here, right? So distance vision, nice and clear, but up close, not so much. Going back to our work from home folks, this example, if we put that extended depth of focus lens in, okay, your computer work vision is now clear, and your cell phone's not too bad, but the fine print is still, small. And then when we go even more here, we can get this, let me get you all the way, to see reading up close. So this book gives a good example. Extended depth of focus lens, the book is okay, and then this gets as sharp as possible for reading vision. Nothing's 100%. You might need glasses for sewing a needle, things like that. Let's look at the nighttime effects of this too while we're talking about it. Standard lens here, right? So everything was really blurry and glare and halo with your cataract. Now, distance vision nice and clear. You can read the street sign up here, get the green there, but dashboard a little blurry, these up close details. This is the extended depth of focus. See how it brings you those glare and halos, but now your dashboard's in focus. The trifocal IOL as well can give you glare and halos around headlights, but bring everything into focus. And here's another good example. Here's reading a recipe in the kitchen. I think this one can be helpful. Again, your standard lens, you've got that nice distance vision. And then as we, hone in, the extended depth of focus decently reads the recipe. The trifocal lens, we can really get that recipe up close. Now, what about astigmatism? So here's where, with a standard lens, if you have astigmatism and we do that surgery, everything is still going to be blurry. You can see that clock on the wall is still blurry. But if we put the toric lens in to correct your astigmatism, now our distance vision is sharp again. And so, and then we can correct your astigmatism and give you up close. So hopefully, I'm happy to run through other scenarios when we get to the Q&A if people would like, but that kind of gives you a sense of the different technologies and what's possible. Further helping us in the OR is some other technological advances. So we use the Aura technology with Verify. So this takes another measurement during cataract surgery. So a real-time measurement of your refractive error after we've taken out the cataract to fine-tune the power of the lens that I'm going to put in your eye to give you the visual outcome that you want. And so it's a very helpful tool for us, especially in patients who have had LASIK or PRK or RK or some sort of refractive surgery in the past. Unique to Pacific Eye, we're the only practice in the Inland Empire that also uses the Callisto computer-assisted cataract surgery suite. So this is technology both in our preoperative measurements and on the table, where we actually take a picture of your eye before surgery and during it, and using the technology of this machine, we can, and let me turn on my highlighter so I can show you here, we can superimpose these heads-up images on the eye during surgery. This allows me to accurately place the lens. The key to these advanced technology lenses is they have to be perfectly centered. So this will help me center the lens on the back of your retina where you see the clearest because of the measurements it takes before. So this is really cool. And then for all of our lenses that correct astigmatism, we have to put those lenses in the axis of your astigmatism. So here these three blue lines are saying, this is where we need to line up that lens to neutralize the astigmatism. And this is important for trifocal lenses, extended depth of focal lenses, and the astigmatism correcting toric lenses to have this technology. It really helps fine-tune the outcomes. The other exciting thing is cataract surgery has the potential to be more than that. If you have glaucoma, you are still a candidate for many of the lenses that I just discussed, but at the same time, there has been this revolution in glaucoma surgery over the past 5 to 10 years, and we have micro-invasive glaucoma surgery, MIGS procedures, that can treat mild and moderate glaucoma at the time of cataract surgery. So one is the eye stent. I really like this procedure. It's 2 tiny stents that are actually the smallest inserts in the human body. are inserted into the drainage system of your eyes, and these create openings for fluid to drain to reduce your eye pressure. And they're only currently FDA approved at the time of cataract surgery. Hopefully down the line, we'll be able to do them as a standalone. You know, you've already had your cataract, but you have glaucoma. But for now, we do it at the time of cataract surgery. I also perform canaloplasty using the Omni device. This can treat patients with any degree of open angle glaucoma, mild, moderate, and even severe. It uses a microcatheter to perform a 360-degree cannulation of Schlemm's canal, restoring outflow pathways of the aqueous humor. That's a lot of medical jargon, but think of it like this. I like to use the kitchen sink drain analogy, right? So you have the stopper. That's where I put the eye stent through that stopper, and then it accesses the drainage pipe. And then from there, it flows into your home plumbing system. So we only have eye drops that can work on the home plumbing system to make that dilate and allow more outflow. But between the stent and the canaloplasty, I can unclog the drain and roto-rooter that pipe until it gets to the house drainage, the house plumbing, so to speak, from this analogy, to really lower your eye pressure as best as possible. I've been able to take patients off sometimes 2 or 3 of their eye drop medications for glaucoma because of the success of these procedures. Again, it varies by everyone, and not everyone is a candidate. So it's really important to have the consultation, and we do a very detailed exam. But they're really awesome procedures to help reduce the burden of the cost of eye drops. You know, as a cornea and dry eye specialist, I see so much of the side effects of these glaucoma eye drops. So it's really nice to be able to treat glaucoma at the same time as cataract surgery. So I know I covered a lot here. I may have talked a little fast. I wanted to make sure I left time for questions. Before I get to your questions, you can start putting them in the box, but we're going to go through the most frequently asked questions. Okay, hopefully this answers a lot, and then we'll take everyone's questions that remain. So is cataract surgery safe? Look, I tell my patients all surgeries involve some risk, but thankfully complications from cataract surgery are very rare. You know, we use eye drops after surgery to reduce the risk of infection and inflammation. There'll be some inflammation. You've had surgery. Your eye might be red. That's all normal, right? But thankfully, more severe side effects are very, very rare. It's a very safe surgery. Does it hurt? Basically, no. We numb your eye. So that numbing drop you get in clinic, we use that same drop as the first step. So you might feel a little burn from that eye drop, but that's it. You get anesthesia through an IV, so you're nice and relaxed during the surgery. You're not put to sleep, no breathing tubes, none of that is necessary. You're awake, but very, very comfortable, kind of like in La La Land for those that are concerned about that. After the surgery, some mild discomfort, like a scratchiness or irritation, or like there's something in there, is normal. We just ask you not to rub your eye. The procedure itself, depending on what flavor we're doing, standard surgery takes 10 to 15 minutes. If we're doing a glaucoma procedure or one of the more advanced lenses and we're taking measurements, maybe it might take up to 15 or 20 minutes. But it's a very quick surgery. You're in and out in a few hours. You go home the same day, which is really nice. And then we see you again the day after, a week after, and then a month after. If we're going to do both eyes, generally I'll do it a week or 2 after the first eye to let things heal up. So what happens after the surgery? You definitely need to bring someone to drive you home to rest because you have anesthesia, so you cannot drive. We're going to give you a protective shield to wear while sleeping for a week or 2, and some prescription eye drops that might actually start the day of surgery, or if we decide to patch your eye closed at the time of surgery, you'll start your eye drops the next day. We ask you to avoid strenuous activity or lifting or bending over, swimming and exposing your eye to dust or grime for 2 weeks. But overall, it's a pretty minimal impact to your lifestyle. You're able to walk and hike and all of those things pretty quickly. It's really the no lifting heavy weights and staying out of like pools, oceans, saunas, things like that. Does insurance cover cataract surgery? Traditional cataract surgery with monofocal lenses is partially to fully covered by insurance and Medicare. So at part of the consultation, we'll tell you if we think it's going to meet medical necessity for your insurance to cover it. What I can't predict, but my surgery schedulers will be able to tell you when they go through the process, is what's your copay, deductible, things like that, because everyone's insurance is so different. Now, if you're going to upgrade your vision, there's some out-of-pocket costs associated with that, but we work with Care Credit and other organizations to offer options for 0% interest financing to help you with that decision so that you can upgrade your vision if you are a candidate and if you choose to. So, is it time for surgery? come in for your cataract evaluation. I am very thorough, which does mean it's a long visit. I think an hour is generous. You're probably going to be more like 2 or 3 hours if you're coming to see me for my first visit here. We're going to dilate your eyes. We're going to do a bunch of tests to assess your eyesight, see if you're having trouble with glare at night, get a bunch of measurements. I'll do the full exam. I'll discuss in depth with you what you do in your everyday life, what your visual needs are and expectations after surgery, so that I can help counsel you on your lifestyle and replacement lens options. And oftentimes I recommend patients to wait. Part of what we do is we'll check and see how good you would see with a new pair of glasses, and that's okay. Oftentimes you might qualify for surgery, but you'd also still pass a driver's test. And I tell patients, that's the gray zone. It's completely elective surgery. If you are happy as a plan, we don't need to do anything. If you are bothered by your vision or glare at night, or you want to see better, then we can do surgery. So it's important to come in, have the consultation, because although cataracts are cataracts, and yes, we do a lot of cataract surgery, no two cataracts are exactly alike, nor are two patients. And so it's really important that we personalize and tailor your treatment plan based on your needs. So thank you all for attending. I hope this has been helpful. I know it's been brief, but there's a lot more detail we can go into here in clinic. And in the meantime, let's open up the questions here, Jana. I'm happy to answer anything that might have come up.
Yeah, so feel free to chat in the questions box while I read off the first couple here. Do any medications predispose you for early cataracts?
Very good question. Yes, the most classic one are steroids. So prednisone or methylprednisone, any steroid medication, or even nasal sprays long-term use of steroid nasal sprays and steroid eye drops can predispose you to cataracts. There's other medications too. We have to memorize a laundry list for our board certification, but those are the most classically associated ones that can be associated with a more younger onset or rapid onset of cataract.
Can an aspheric cornea or other corneal problems cause problems with the Synergy IOL?
Yeah, so aspheric cornea, all cornea has some sphere to it, so I don't know exactly what you mean there, but yes, cornea problems for sure can cause problems with any sort of diffractive IOL. So the trifocal lenses are diffractive lenses. They have rings which split the light. And so that splitting of the light allows you to get your focus in different planes, but it splits the light. So if you have really dry eyes, well, that's already scattering the light. So I tell my patients it's like putting a Ferrari inside your eye. But just because you have a Ferrari, if you have a faulty transmission and your windshield's cracked and dirty, you can't drive that as fast as it's designed to go. With these lenses, you need a perfect optical system to make use of lenses such as the Synergy and PanOptix lens. And so that's part of the evaluation.
Okay, I have a bleb with narrow angle glaucoma. I have a cataract, but have been told to wait. How difficult is the surgery with this issue?
Great question. So cataract surgery in the presence of a previous trabeculectomy, certainly inflammation from the cataract can cause scarring of the bleb. So that's always a concern with pressure changes. Narrow angle glaucoma, though, well, that's often exacerbated by a cataract because the cataract is closing off the angle, can be, and this is where the evaluation comes in. We'll look at that under the microscope, can be closing off the angle, and cataract surgery alone creates space in the anterior chamber, allowing for that angle to open and outflow to occur. Now, if there's like scarring of the angle or something like that from chronic angle closure, that's not going to change so much. It does make it a little more complicated in terms of potential damage to the cornea. So we'll evaluate the corneal health as well and the cells on the back of the cornea in the pre-op appointment before going forward with surgery. You might have been told to wait because of concerns about the bleb specifically. And this is something where we would coordinate with your glaucoma specialist if they wanted to do the cataract or have us, or we work together as a team to see what's best. But if your vision's affected and it's bothering you, it's worth, checking out and seeing if we can help.
Perfect. Can the iStent be be performed after you've had cataract surgery if you later develop glaucoma?
According to the FDA and covered by your insurance, no. So insurance will not cover an eye stent if you develop glaucoma later. Insurance will cover canaloplasty, so the second procedure I talked about where we open up the drainage system, and you are entitled to pay out of pocket for any procedure you want as long as we think it's medically necessary and your surgeon agrees to it. So have I done eye stents in patients who either later developed glaucoma or especially when they first came out, had already had their cataracts but would have been great candidates for the eye stent? Yeah, sure. It's expensive, but it's an option for you. But in terms of, would insurance cover it and has it been as studied? No, it's an off-label use.
Okay, I'll leave it open here for a few more seconds here to see if any additional questions come in.
These are great questions. And if anyone has any other scenarios or anything else they want me to show on the vision simulator, I'm happy to toggle back to that as well.
One more question just came through. How many doctors are there with Pacific Eye, and who are the cataract surgery specialists that also handle glaucoma?
Great question. So we have, let me think here. There are 5 of us that I can think of, or 5 or 6 of us offhand who do cataract surgery in combination with glaucoma. We all have different degrees of glaucoma training. So for example, eye stents and canaloplasties can be done by doctors who are cataract surgeons, general ophthalmologists, cornea specialists. I did a complicated anterior segment fellowship that involved glaucoma care and these types of implants. And then there are fellowships specifically in glaucoma where you learn more of tubes and trabeculectomies, and we have 2 doctors who did those fellowships. So we have a breadth of different doctors who treat different degrees of glaucoma.
Okay, perfect. Well, that looks like that was the last question. We are going to send the recording of this webinar out sometime this week, so watch your emails for that. And also feel free to schedule an appointment. Visit our website, pacificimd.com, to get the contact information and check out our locations. But we hope to see you soon. Thanks for coming to the webinar. Oh, somebody actually just chatted one more question, so
Sure.
if we can sneak it in there, I'll I can see out of one eye and had surgery in my left eye. What do you recommend for my good eye?
Is the good eye, I don't know which your good eye is, if that's the eye that had surgery or that's the eye that didn't, but once we're talking about a monocular situation, that's something I can't answer over a webinar. I definitely recommend you come in for an evaluation so we can see what's going on. Bring any medical records if you had care elsewhere with you. That's always helpful when you see any doctor. If you're going to a new doctor, especially in the ophthalmology world, bring any of your old records. It's really helpful depending on what condition we're working on. Chronic conditions like glaucoma and such, it's helpful to know the history. But to your question, I would need a lot more information before I could tell you what I'd recommend for the good eye.
Okay, perfect. Well, thank you, everyone. Thank you, Dr. Smith. Have a wonderful rest of your day.
My pleasure. Thank you, everyone. Take care. I look forward to meeting you soon.